I'm really sorry to break up all the conversation out there. But we're going to go ahead and get started on our panel discussion of hurdles and solutions. And we are going to be led in this discussion by our moderator, Erin Morin. So let me introduce Erin, and then she will introduce each of the panelists. So Ms. Morin is an environmental health specialist at the Association of Public Health Laboratories, focusing mainly on wastewater surveillance. After receiving her bachelor's degree from Gettysburg College in 2017, she worked in a water testing laboratory for a year before entering into graduate school. In 2019, Ms. Morin earned a master's degree in environmental health from the Johns Hopkins Bloomberg School of Public Health, and she has been at APHL ever since, starting as an associate specialist, focusing on biomonitoring and laboratory response before being promoted to her current role. All right, take it away, Erin.
Thank you, Anna, and hello and welcome to the Hurdles and Solutions panel discussion. Like Anna said, my name is Erin Morin, and I am the specialist for environmental health at the Association of Public Health Laboratories. Sorry, I had some of my bio written down, so I'll skip over that. I'm sure each of you know that establishing, maintaining, and expanding a wastewater surveillance system comes with its fair share of hurdles to overcome. This panel discussion, we wanted to give everyone a chance to hear from a select group of professionals about the challenges they have faced and how they have overcome those obstacles. The panel will represent key stakeholder groups in wastewater surveillance programs, including epidemiologists in state health departments, specialists in public health laboratories, researchers in academia, and wastewater professionals from utilities. Please join me in welcoming our panelist. Dr. Michelle Crum is currently an associate professor at the Department of Medical Education and the interim chair for the Department of Preventative Medicine and Population Health and administrative lab director for the Public Health Laboratory, all at East Texas UT Tyler School of Medicine. She has experience in molecular biology, virology, and pandemic preparedness, and is the director of Invaders and Defense, Microbiology, and Immunology at the newly formed UT Tyler School of Medicine. Her interests include emerging and reemerging diseases, pandemic preparedness, response mitigation and prevention, and the promotion of health literacy against these threats. Mr. Ryan Jepson is the Environmental Microbiology Manager at the State Hygienic Laboratory, or SHL, which serves the state of Iowa's Public Health and Environmental Laboratory. He has worked at SHL since 2008 before moving to environmental microbiology. Mr. Jepson was the clinical microbiology supervisor at SHL, where he implemented testing for antimicrobial resistance laboratory network and participated in the transition to whole genome sequencing for PulseNet. He oversees microbiology testing of food and water in support of outbreak detection, FERN, Safe Drinking Water Act, and the National Wastewater Surveillance System. Dr. Rachel Poretsky is researches microbiology, ecology, diversity, community structure, and interactions in aquatic environments. She has done pioneering work looking at the genes and gene expression of microbial communities in the open ocean, freshwater lakes and rivers, and wastewater. She is currently the scientific lead for Chicago's and Illinois' current wastewater surveillance efforts, where she partners with the Discovery Partners Institute, Argonne National Laboratory, Northwestern University, Rush University Medical Center, and Chicago, Illinois Department of Public Health. In 2021, her lab was designated as a Series Nanoscience Wastewater Epidemiology Center of Excellence. Dr. Lisa Thompson is the chief scientist of the Sacramento Area Sewer District, which serves 1.6 million people in Sacramento County, California, and surrounding areas. She leads and supports district's efforts regarding compliance with permit-related studies and engagements in Sacramento and the San Joaquin River Delta research. Dr. Thompson serves as a technical resource for scientific researchers' needs for the district, including wastewater-based epidemiology efforts. She holds a Bachelor of Science in Zoology, a Master's of Science in Biology, and a doctorate in zoology. And finally, Dr. Alex Yu is an infectious disease physician and serves as chief of the surveillance section in the Division of Communicable Diseases Control at the California Department of Public Health. He provides clinical care at San Mateo County Medical Center and holds an adjunct clinical faculty appointment at Stanford University. Dr. Yu completed infectious disease fellowship training at Stanford University, internal medicine residency at Massachusetts General Hospital, and his master's in public health at Harvard University. We will begin today's panel with introductions from each of the panelists so that you may get familiar with their experience and backgrounds. Afterwards, we will open the floor to questions from the audience, both in person and on Zoom, at which point you may queue up the microphones and ask your questions. Then we will toss the question to the appropriate panelist or panelists to discuss. Lastly, with the final minutes of the session, we will go back to each of our panelists to summarize their thoughts from the discussion. If you are able to walk out of this room with a new idea of how to solve your problems, I will consider that a great success. And that should be easy to do with the group we have here today, but we'll move on to Michelle.
Good morning. So I'm from the Public Health Lab of East Texas, and we are a relatively small local public health lab that's located on an academic campus that's also considered part of the state government through the UT, University of Texas system, on a health science center campus. So we are pretty unique as public health labs go. And just basically to share a little bit about us, we originally got started in wastewater efforts after discussions for almost a year. So it did take a little while to get folks on board. In addition to that, we're not eligible for ELC funding. So we are part of clearly we're located in the state of Texas. And as part of that, Texas decided to not have a statewide surveillance program for wastewater. So because of that, we really needed a different source of funding. So when we were interested in doing that, we were looking at what are the technical challenges that we might need to consider in taking this on and what's the best way to get started. And through a call with the APHL wastewater community, we connected with Ceres and did become the first Ceres Center for Excellence in Texas. And Houston is now joining that effort as well. And we're working with them as they're onboarding the Ceres technology. So we're pretty excited about that. Houston had the one of the first and is the largest still existing wastewater surveillance effort that we have in Texas. And so we're very excited that they're now a part of the Ceres effort and in anything that we can do to help them on board with that. We're currently monitoring about 5 sites. So in East Texas, our lab actually serves about a 35 county region, which is a equal geographically and in scope and population size to West Virginia. And we serve a population just under 2 million, but we're very spread out and have a lot of rural communities that we are not currently including in all of our wastewater surveillance, but we're looking to try to include that in the near future. In addition, we want to increase our menu of pathogens. I think everybody's looking at the respiratory pathogens as their next, and that is also our next direction, followed by enterics and possibly AMR in the future. We have a fellowship program where they were not originally called this, but they're called the Public Health Fellowship Programs through APHL, Public Health Career Pathways Fellowship Program through APHL. So at the very beginning of our program, we had an environmental health fellow that helped us to coordinate all of the efforts. And I know we're going to talk more about challenges coming up in just a minute, but we've been able to have fellows included in our program to help both further their experience in education and assist with our program as well. And we have an infectious disease fellow now that's helping begin sequencing efforts in our laboratory. The other things that we're doing are establishing a dashboard for the public use, and we're working with our regional health department to develop that. And that has been an ongoing effort that we've had hurdles to as well that we'll discuss today. And then, of course, our ultimate goal is actionable public health results is what we'd like to eventually see. So we're working closely with our public health partners regionally to establish that. We've also connected with our regional department of state health services. And that's a different relationship because that's, really more a state connection. But we do want to be able to provide that data for anyone that can use it so that we can really respond the best that we can to whatever pathogens are next. Thank you.
And we'll move on next to Ryan Jepson.
Okay, can everybody hear me with this? So yeah, my name is Ryan Jepson and I work at the State Hygienic Lab at the University of Iowa. We're one of the few public health labs that's part of the university as well. And my journey to COVID wastewater testing starts back in the early days of the outbreak. In May 2020, I was the clinical microbiology supervisor at the lab. Our molecular virology unit had brought up the CDC assay and was having some issues. So they were working on those issues. At the same time, I was asked to switch and actually bring up our private COVID testing unit. So I spent the first 6 months, I don't know, from March through September, maybe October, getting that online. That eventually went on to test something like we did over 2 million COVID samples. I went back to my normal job, and my predecessor, an environmental microbiology manager, actually went and worked with some of our staff that we had hired in our private testing unit to develop wastewater testing using just routine quantitative PCR with membrane filtration. Then soon after that, she retired. I applied for her job and took it, and I was tasked with getting droplet digital PCR going. So we actually had purchased a QX1 instrument, and that started, actually I have my notes, back in November of 2021. I was asked to come on with that team. We started out thinking that February 23rd, we had a due date of April 1st. And we figured that the LOB would take 4 days, the LOD was another 4 days, LOQ 5 to 10 days. We figured we could do all of this and go live from February to April 1st. And that didn't happen. We didn't even come close to that. The one thing that we realized very quickly is that while we have a lot of molecular experience, actually had several PhDs with molecular biology, PhDs in molecular biology, this was just a different type of test than we were used to dealing with. And we'd gotten so confident after rolling test after test and troubleshooting throughout COVID that we thought this would be no different. And it did turn out to be very different. So then it ended up that we worked on developing this assay, troubleshooting the assay, going back and forth. We ended up actually coming to restart our validation in July. And then I ended up talking to a few other labs, and we discovered the Ceres nanoscience particles. And what was great about this is we had really started trying to build our program from scratch. So that involved the QX1, it involved concentrating pipette. Those two things we didn't have any experience with. What we did have experience with were kingfishers. Everything that we did for COVID response was based around those kingfishers for extracting DNA. So pretty quickly after we got those nanoscience particles, we were able to finish our validation at the end of last year. And we used the SARS prevalence kit, and we're now testing, I think we're up to 27 counties across the state of Iowa. We have a population of about 3 million people. And we are now doing at least one sample from every single site. And we're just starting to pilot a second sample from our one of our larger submitters, the Quad Cities. During this time, we actually started doing the dorms across the University of Iowa. And so that kind of was a bit challenging because, with grab samples, they're not representative. They do different things than composite samples. And I think at times that made troubleshooting the assay a little bit more difficult too. So yeah, I think at this point we're up to 27 counties. We have 99 counties in the state of Iowa, and we're sequencing, and we're getting ready to bring on flu and RSV. We've gone ahead and purchased additional instruments. We have 2 QAQUity4 instruments. We also have a Biorad QX600. And I think we're just really trying to ramp up quickly. Thank you.
Great. Thank you. Next, we'll move on to Dr. Rachel Poretsky. Bear with me. These slides are in a different order than I was thinking.
All good. Oh,
There we go.
Hello. Hi, everyone. So Kaylin gave a good overview of our timeline in Chicago from the MWRD perspective. I'll just, I guess, tell you a little bit about the lab side. So we started in 2020, pretty soon after everybody was sent home. I had been working previously, prior to COVID, on some wastewater projects looking at microbial communities and even viruses, but not the kind that make you sick. I'm just looking at general viral communities in wastewater here in Chicago and in neighboring states in Wisconsin and Michigan. And so we were sent home, and a couple of us got together and we're like, well, we know how to do this. And there were some people who were already like starting, people who had started a little bit before us, and we formed this community, putting together methods. And we had a postdoc at the Discovery Partners Institute who helped use social vulnerability indices to choose sewer sites in the city of Chicago. Where else were we in the beginning? I think we started pretty early at Cook County Jail, the big jail in the city, and then the MWRD treatment plans. And we worked out methods. All of this happened with some of my PhD students and some of my undergrads in the lab of my colleague at the UIC School of Public Health, Dr. Abhilasha Shrestha. And she actually she has a contract with the city of Chicago for years now, where she runs all the beach monitoring. So from Memorial Day to Labor Day, they collect samples at every public beach along the lake here. And early in the morning, bring it back to her lab, and she runs qPCR for enteric bacteria, and they notify whether the beaches should stay open or be closed. So she was well poised, it wasn't beach season yet. And so she had the capacity, a lot of qPCR. And so we were doing this in the city of Chicago. And then when we were approached by the state to expand, the state has a couple of public health labs, like many of the folks here. And initially they asked us to help them design the wastewater program to bring into their clinical labs. And so we met with them a bunch and told them, well, first you get the wastewater. And then they were like, wait, we're supposed to put wastewater in our clinical labs? And we're like, that's how you do wastewater testing. You got to start with the wastewater. I said, we can't do that. We can't have wastewater in our labs. Will you do it for us? And so we built this the statewide program, and we'll talk about some of our challenges in the whole grand scheme of things. But one of our biggest challenges was going from the 10 or so sites that we had in the city of Chicago to 80, 85 sites around the entire state of Illinois, and building up that program. And a lot of it involved building up automation and capacity to do something that was initially very manual and very research-based to something that was more for public health action. And so we've sort of transitioned to, this was in 2021, I think. All the dates are a bit of a blur during COVID, but sometime around then we transitioned to the statewide program. And we've been working a lot with how to interpret data, how to make it actionable, how to expand targets. So Kaylin mentioned we do RSV and influenza and polio and all the Mpox and all sorts of other things. But a lot of it is reactive, and we're thinking a lot about how to be more proactive, because wastewater has everything in it, whether you're testing for it or not. And trying to ramp up when there's an outbreak already known, or the fear of an outbreak coming, doesn't seem like the most efficient way to do something that can be that can give some sort of advance notice. And so our challenges now are kind of expanding targets, thinking about ways to do more broad surveillance, but also communicating the data, interpreting the data, communicating the data, and making sure that they're actionable to our public health partners.
Okay, thank you. And next we'll move on to Dr. Lisa Thompson.
Okay, how's that? Hear me? Cool. Hi, good morning, everybody. Great to be here. I want to give you a bit of a perspective from a large wastewater treatment plant. You already heard from Kaylin this morning about Chicago's experience, and a lot of that rang true for me. My main take home, though, is I think in order for us to keep really sustaining the wastewater-based epidemiological sampling in the long run, from the wastewater treatment standpoint, in terms of funding for doing that, it really would be helpful for us, for public health, to be articulating every chance you get what you're doing with the data that you wouldn't be able to do if you didn't have our data. How does this take you beyond the clinical case data? Because here's, I'll kind of walk you through now our treatment plant's experience, but think about that because everything I'm going to say is in line of that. So so we started sampling in April 2020. We started sampling actually with University of Arizona. Then we started working with Stanford, which grew into the wastewater scan program. We've also sampled with BioBot every time it was free. And we've been able to sustain that. We were able to get it going so quickly, partly because of just happenstance of where my position is within our organization. So I'm a chief scientist. I'm under a director who's under a general manager. I'm two heartbeats away from the top of it where the funding hits, which is with our regional board. Our regional board is basically the county board of supervisors for Sacramento and representatives from the surrounding cities that we serve. So everything we do comes from our National Pollution Elimination Discharge Permit, NPDES permit, and from our regional board directors getting us to do stuff. So that's why we do stuff. Either we're mandated to do it by our regulatory agency or we're told to do it by our regional board, sometimes both. So we were able to say, hey, it's an emergency. This looks like it would be helpful. You know, everybody all hands on deck for doing stuff about COVID. We got that sampling going right away. Keeping it going, it's like, okay, why are we keeping this going? And so, you know, we do things that aren't under our NPDES permit, but it comes from our regional board. And so we serve about 1.6 million people. We're relatively big. It's all one treatment plant. We can pull one sample and represent the whole community. So you think, well, that ought to be easy. You know, why are we having trouble justifying this? But if you think about it from our lab manager's standpoint, so whenever we get a call in, can you do some wastewater sampling? I get on the phone. I don't email. I get on the phone with Dr. Shrivi Ramamurthy and I go, Shrivi, can you guys pull another sample? And she talks to Mike Cook, our water quality lab supervisor, and Mike goes, yes, we will make it work. And Mike goes and makes it work. So I always think about Mike getting one of his staff to go pull this extra sample. It's about 470 extra samples we pull. Thankfully, we get to ship them out. They either go FedEx or courier, which is super helpful. I think if it weren't that easy, the whole thing would be a lot tougher for us. But it's not enough samples for Shrivi to justify to her director, can I have another staff person? It's coming off of Mike's people over and over again. So if and we feel like it's worthwhile. I mean, wastewater treatment plants do public health. You wouldn't have a Chicago, you wouldn't have a Sacramento, you wouldn't have a New York City. You can't have a big city and have it healthy without wastewater treatment. We get that. It's just that the influent part is not our mandate. We get mandated on what goes out either to recycled water or to a lake in the case of here, to a river in the case of my treatment plant. That's where the rubber hits the road for us, and we have to be on our game. So if somebody ever felt, I don't think they do, if they ever felt, hey, you know, having our lab staff to diverted to this other stuff isn't effective, well, that would be a problem. But I think it's probably going to work out for a plant as big as ours, as long as we can justify to the people who tell us what to do why this is valuable. And I see the value. It's been interesting over the course of the pandemic. Initially, we'd send the BioBot reports off to our public health and they go, that's nice. And they never had time to call us back because they were just so busy trying to figure out where do we test, what's happening to the hospitals. And then gradually, as the amount of case testing went down, they're like, we don't have enough data. Oh, we have this wastewater data. And it was so lovely seeing that shift and seeing the shifts in all the graphs where initially, you know, you had the wastewater data and we didn't have enough tests, you know, to catch up with the peak and what was happening. And then by Delta, everything matched up. And by Omicron, hardly anyone was getting tested and not as many people were getting sick, but you could see this huge spike in the wastewater. So the wastewater was always there and it's been so cool to see that. So making the case whenever you can, getting people aware of the dashboard. Somebody mentioned that this morning. When you show people the dashboard, they're like, oh, this is so cool. You know, I have a cousin in Ottawa, Canada, and she's like, oh, I go to the dashboard all the time for Ottawa to figure out what I'm going to do, right? So I think when that becomes more like everybody knows about it, then it's not going to be an issue. Then our regional board's going to go, of course we want the wastewater data for our community. That would be stupid not to pull one sample and have us know how our public health is doing. So that's my take home. I'll stop there. Thanks.
Thank you. And lastly, we have Dr. Alex Yu.
All right, thanks everyone. Yeah, so I'm Alex. Yeah, I work at the California Department of Public Health and serve as our chief of surveillance there and lead our wastewater surveillance program there. And if I think back, to the pandemic and how our wastewater program got started, we really, we started in the fall or winter of 2020 with some seed funding from when CDC ELC News really got started, and that gave us just enough funding to hire one person, Angela, who's here with us. But we started off as a really small team, and up to that point, I had been working in different parts of the pandemic response, served as clinical lead. I did a lot of outbreak investigations. My background's been in outbreaks and surveillance primarily, as well as clinical ID, and also working on different nursing home outbreaks and trying to help develop strategies for nursing home prevention. And I think when wastewater surveillance hit CDPH, really it was partially kind of like we had this funding that was available and we should take advantage of it, not because we necessarily knew what we were going to do with it, what wastewater surveillance was. Really, I think to the public health world, the idea of doing environmental sampling for the purposes of surveillance is just totally foreign, right? And everybody's busy as it is. And I think I got assigned to it partially to give myself or to give me a break, and also because I had a newborn and people didn't want me to travel, and this was an opportunity to do that and maybe kind of like get me out of everybody's hair for a little while. And it wasn't because they believed in this program per se, right? But we had this funding, we hired Angela, and we quickly, without other funding, we turned to people who we could partner with at the utility side, people who had more experience in this, Cali, PA, state water boards. And we tried to piggyback of work that other people were already doing. And that really has been early on and throughout the pandemic on the backs of people who've been champions at their utilities, at their local health departments or otherwise to be participating. A lot of it's been in-kind services, a lot of people who put in their own funding, whether it's on the utility resources collection perspective or labs contributing their own dollars, whether it's academic or otherwise, to be a part of this. And really, it's been sustained through CDC, right? At the state level for us. But that over the pandemic has really changed, right? It's only been a couple of years, I guess. But really, in the last 3 years, we've seen wastewater surveillance to be, front page headlines in a lot of places. It's really been now like every time people talk about what's the state of COVID, they say, well, the wastewater data says this, right? And this is a totally different world than we were in a couple of years ago. And at the state level for us, we went through, small seed funding to getting more funding from CDC ELC. Now we have a team of EPIs. We've built out a state lab that can do high throughput sampling or analysis. We have multiple different sources of data that we collect from within California. We take advantage of the BioBot program, of the wastewater scan program. And we even got state funding, which really, really helped. But then, here we are now at this kind of inflection point where public health interest has really declined. The kind of national attention is subsiding. We have a big state budget deficit, and so we no longer have any state funding. And really, this is the same question that's facing public health departments everywhere, right? Which is, where are we going to be? How can we kind of come out of the pandemic stronger, but with pre-pandemic funding and resources and all these things, but the expectations of pandemic, right? And this is the same problem that's facing wastewater in general. And so as we move forward, we're thinking about, how do we want to grow wastewater and things like that. But a lot of it's really about how do we make wastewater sustainable? We believe it's core infrastructure for public health as surveillance tool. It really, I think the fact that wastewater stands up to COVID-19 case data and all this other stuff that came out of the pandemic is incredible, because COVID will be like the most well surveillanced disease entity that we'll ever have. Well, I don't know about ever, but we've had to date, right? It's so much better than anything we've ever had, and much better than flu, and much better than things like norovirus that we get no data for. And so the fact that it's worked so well has been really incredible. And I think it can be a pillar of public health. But the question is, how do we get there? And a lot of that's around sustainability. And that's not just sustainability at the public health level, but it's for utilities, right? Making it work when utilities are just doing this because of essentially because they believe in the mission. And we had to make that case, right? We had to work with other people. We had to learn from engineers and utilities and other people that really, frankly, public health is medical people. Everybody is really not familiar with working right with, and we had to get out of our silos. And I think that's been really difficult. And even within the public health sector, it's really important, right? Working between lab and epi is not something that we're necessarily super used to, right? And as we think about new pathogen targets, and things like flu and RSV are like kind of obvious, right? But at the same time, they're not the ways that we've done public health in the past. Or we've been doing flu surveillance for forever, the way that we've done it. And so why add wastewater, right? What is that value add? And is it worth the extra dollars and efforts and things like that, right? It's a new data source, and public health departments are already stretched thin. And so how do we make the case that this is something important for us to do? And so sustainability and growing wastewater surveillance is going to take a lot of effort and a lot of coordination between groups, whether it's within public health, with utilities, with civic groups, with the general public. It's about communication. It's about coordinating all these programs so that, I think one missed FedEx courier pickup may be the difference between a utility that has two people to be able to participate or not, right? And I think being able to coordinate and understand those things and trying to secure resources to try to support people as much as possible to make it sustainable, I think all of those are the challenges that are ahead of us. And I think we're at this opportunity point where we can try to gain or take advantage of some of the resources that are still available from the pandemic. The interest that's still there, the fact that the general public still kind of cares about public health and all these things, to kind of leverage that, right? To be able to put pressure on leadership, hire elected officials, et cetera, to say this is something that's important and that we should do. And I think those are the kind of challenges that we're thinking about and trying to make the case for public health and wastewater surveillance. All right, some general thoughts, but a lot of the kind of same themes that you guys have heard throughout the morning so far, and I'm sure you'll hear more about.
Okay, thank you all for those great overviews. We'll move into our Q&A portion now, and since Sandy wasn't able to make it, we'll have a little bit more time. Anna also let me know that John Person is on Zoom and able to answer any questions you may have for him as well. Okay, Anna, is there any online questions?
You all hear me? Okay, great. Thank you. So this is a question from online. There is often a focus on making data actionable. Is wastewater surveillance only a success when the data are actionable? Are all our clinical surveillance data always actionable? And I would just add, what does actionable mean?
I can start with that one. Yeah, it's a really good question. I think we get asked this all the time. And I think my response now is probably a little different than it would have been like 2 or 3 years ago when we were first starting this. And I think it is really important to think about, why are we collecting data and doing this? It's having more data just for the sake of it, or if we're not going to do anything with this, is a waste of everybody's time, right? Even if it's nice and pretty and looks good, right? But that said, I mean, it's true, right? Surveillance data is only, for any surveillance system, it's only useful when we need it, right? And we don't necessarily do something with surveillance data when we don't need it, right? Like, we could be monitoring for polio, but if there's no polio cases, then we think we don't care about it until there is a case, right? And things like that. There's different corollaries. And beyond that, I think that, I think from the non-public health perspective, I think there's a lot of value to wastewater surveillance beyond public health and immediately tying to actionability. I think clinicians can use it. It's really important in the hospital. I think it can be useful to researchers to understand the epidemiology of viruses or pathogens. I think there's lots of value add beyond all of this, right? We can make the case that we don't need to monitor for COVID in this, current post-pandemic kind of state, and we could just rely on hospital beds or something like that at this point. So what's the added value of all this extra work for wastewater surveillance? And I think there's way more uses for it beyond just like direct public health actionability. That said, I think wastewater is not, we can't put it into the same bucket where it's a brand new infrastructure that we have to get resources for. It does mean taking resources away from other things to do this, right? To understand it, it is a new system that we don't know how to use. To really make the argument for it, we do have to figure out what are the actionable steps that we want to take from wastewater and make the case for it. And if we can't do that, then I think it is a good question that, should we be doing this for this pathogen at all, et cetera? Is it worth the extra efforts when we're burning through goodwill to try to get these systems set up. And so I think it is critical that we still focus on those pieces. And if there are cases for it to be being useful for the public, for clinicians, or for other things beyond public health, I think we need to also capitalize on those messaging and understand how we can use that to support wastewater surveillance if we think it should be done.
I'll add too, I think it has to be actionable, but it doesn't have to be immediately actionable. So I think a lot about how you mentioned flu surveillance, like the regular routine flu surveillance, influenza surveillance in this country could not pick up COVID. It was not designed for this particular coronavirus, right? And so, and among other failures in the beginning of the pandemic, there was no clinical testing. It was slow to roll out, and then it was botched, and then finally it worked. And so we think a lot about, like, if we had a wastewater surveillance program at the scale that we have now, back in the 2020, even the end of 2019, we could have gone back to samples and known exactly when it would, we could do a little bit of retrospective analysis and gone back to those samples and seen. Everybody was concerned when it would first arrive in their community, when it would first arrive in the US, and when it would first arrive in their community. And we had wastewater, we could have seen that. And so that's not something that we could have predicted, but it's still actionable data that we could go back to. And so some of these targets are things that are directly actionable at the moment, and some may be in the future useful and actionable. And some, like polio, like if we don't look for it, we'll never know. And all those reasons that everybody's mentioned about polio, like until there's a case, and then it's bad press, and it's bad for the person who got paralytic polio, and it's a terrible situation. But if we look at the wastewater, we can know beforehand. So there's different levels of actionable. I think to do wastewater surveillance, it has to be actionable, but what that action is going to be different depending on what the target is.
Yes, I think I'd like to add to that too, to say, if we really want the future to be, and, taking this data and making it actionable, we have to think about what makes sense to the general public, because in the long run, that's what we're going to need for sustainability. So we might think about, let's say you look at the weather in the morning, and I know you don't necessarily believe it 100%. None of us do, because we know it's changeable, but you look at it and say, it's raining today. I'm going to take an umbrella. I'm going to take a coat. I'm going to decide to wing it. I'll be fine. I'm inside most of the day, right? You make these decisions every day. What if we could make this data actionable so you can make a decision about how you're going to either mask or decide to interact with people or get vaccinated, or what things you might want to do to protect yourself if you were to go out into the community? We're not quite there yet. But the ultimate dream would be to get there, where it's a sort of forecasting availability for those in the public, and you give them the tools that they need to make that decision.
Okay, we can move to an in-person question. See a hand raised in the back. And am I using this mic? Or do you have a wireless one? Okay. In the back of the doorway.
Building off of the comments on the notion of the actionable data, there's also kind of the double-edged sword with that. If we keep marketing and progressing with wastewater as actionable, similar to what a lot of the universities have done, where they shut off more individualized testing, or basically don't want to collect the data because it becomes actionable. Would this also be something where initially, by demonstrating the power and resource of wastewater, would also then motivate more people to stop testing in the longer run?
Yes, absolutely.
Thank you. And maybe to build it so it's not just a yes and no, is what could we actually as a community communicate that of the power of wastewater surveillance? Is it solely on the actionable? Is it more of where it's the kind of weather monitoring, where it's just information that's out there for community decision? Or is it something even that we haven't found as the right kind of vernacular of what we're trying to pitch?
there's probably a balance, right, of like what is measured and what is reported to whom. And so some things maybe just go to the public health departments. Some things maybe go to the community. There's this concept, right? A lot of people have heard of the worried well, like we don't want to make everybody panic, especially the people who are already super vaccinated and are going above and beyond. And then they're the ones who are going to try to get, polio boosters and stuff. And so we don't want to make people panic, but there's probably like a balance between what's measured and who who gets those data. And so I think that's something that we have to think about. Like maybe not everything goes on a public dashboard, and maybe the way we present it on a public dashboard is dependent on what that target is. Like I don't think we're going to get it. There's a question this morning about the different is there are we politicizing COVID, right? And so maybe I don't think people can argue that knowing whether influenza is present is a threat is controversial, but other things are. And so maybe the way that's presented kind of depends on that. And that's why we need, the public health experts, the clinical experts, lots of people coming from different backgrounds contributing.
I would agree with that. I wasn't sure if you had a comment down there. I would agree with that and say having specific messaging and data sharing for specific audiences is really important, as well as having that plan of what you'll say established to where like you mentioned, the vernacular is appropriate for that audience, because what the public wants to know versus what your health department wants to know versus what clinicians want to know is very different. And I don't know that we've quite established how to bring all of that together at this point. Definitely, I mean, a good example is that with sequencing, that we oftentimes, when we started sequencing, there were questions about, can a doctor call and get the sequencing results for his patient? Well, for one thing, it's not going to help much anymore because, that's fairly far down the road from when they probably already recovered. But also, does that assist them in any way in treating the patients that they're seeing, in the near future? So, that's something that has been questioned in the past. So I think we have to consider how to best share data with the right audience, and then how to develop those messages that make sense.
Okay, thank you. Is there any more questions from online?
There is another question from online. So we'll do that, and then we'll go to you, Erin. Another one is there something you think that you all think can be done to better acknowledge the contributions of utilities?
So utilities traditionally try to be under the radar. They don't really, yeah, Kaylin's nodding. Yeah, my utilities become a lot more outgoing in the last 10 years because we went through kind of a nasty lawsuit about permits and stuff. But we've spent the last 10 years really being more outgoing. That's part of why my job exists. Me and my very small staff are out a lot in the community, the environmental community around Sacramento, working with people who study what our wastewater may or may not do to the river where we discharge. So we're pretty tapped in, and that's happened across our agency. We're getting used to being more visible. Actually, with our wastewater data, my director at the time did a ton of media work. Whenever an interview would come in, please tell us about the wastewater COVID monitoring and I'd brief him on the latest data, and off he'd go and give these talks. So we're getting more used to that. But in terms of acknowledging, it can be pretty low key. It's mostly engineers. I'm rare-ish being a scientist, and they don't usually like being called out. I think it's nice if you're talking about the data saying, and our local wastewater treatment staff have been collecting these data weekly, daily, solid without a break for 3 years. And when I get a chance to acknowledge them, I do that. Like every time I give a talk, especially internally, and our staff did this, not me. But it doesn't have to be huge. And I don't think it's the recognition that would keep us going. It's like I said earlier, it's having the local public, the politicians, and therefore our directors know that the data are useful. Then we're going to find a way to do it. We're not going to go, oh no, we can't do it. Right. But so just enough of an acknowledgement that our directors can turn around and know that our board of directors have heard this, that the local politicians who represent our ratepayers and all the local people who are going to be paying for all this anyway, one way or another, that they all know, oh yeah, our treatment plant does that. It's useful. It doesn't have to be huge. We don't want banners. Yeah.
And I think too, we work with these treatment operators all the time in a routine testing fashion we have for years. So they know the staff at the laboratory. And so for us to ask them to do this, it's, as long as they had the tools to do it, it usually wasn't that big of an ask. The other thing that's been a positive is some of the local county health departments will actually collect the samples, and then the operators will collect the samples, but they'll go pick them up for them, and they'll take them the kits if we send the kits. So typically, so I think having that local presence that's able to help them is good. I've also heard of other public health labs or health departments using funds from the ELC to pay for the labor to collect these samples. But we can't do that because we're a subcontractor with our relationship with the university. But I do think that we've had these relationships for years. One of the other thing that we do is when we issue a report, all of the local health departments have web access to our LIM system, our laboratory system for the results, but we do send a paper report to all the operators so they get to see what they're generating from the data. And they've been appreciative of that.
Just real quick, that reminds me that we recently started offering continuous CEUs for our operators to attend monthly. We just kind of like Wastewater Scan does, like a lot of, we give monthly updates. And one of our program managers at DPI managed to arrange a way for the utilities to get CEUs for attending. So I think that maybe more, I don't know, money's always good, but CEUs are important too.
I love that idea. And I want to say that we look at our wastewater treatment facility partners as partners in not only the project, but the science. And every time that we can, we try to at least have a monthly meeting with them. They do get data on a weekly basis, and we sample twice weekly. But we also want to make sure that they feel included in the process because I mean, they're scientists too. They have questions, many of them, about what this means and what's happening. And it's a really important piece, I think, that Ryan brought up about that relationship. That was one of the hurdles at the beginning is how do we start this? And our environmental health director at our regional health department was able to already, because she already knew some of the local facilities and their operators, she made that outreach to them to initially introduce the project. And then we introduced our team, and it really just went from there. And if she wasn't able to make that connection, I don't know how difficult it would have been for us as an academic institution to make a cold call to a utility and say, here's this crazy project that we want to do that maybe you've heard about this wastewater surveillance, maybe you haven't. And so it does really focus on relationships, sharing the science, letting that drive you forward.
Okay, we'll move on to Erin.
Hi, I'm Erin Bivens. Thank you for your leadership in this space. There's a question I've been kicking around for a few months now, and I'm kind of curious to hear your thoughts on it. I'm a public health amateur, not an epidemiologist, but the question I've been wrestling with is how many cases of COVID-19 have we prevented? And how do we quantify that? And how do we, because I think there's, of course, we need to champion resources. And I guess it seems to me we need to make the pie bigger so that it's not zero-sum game. And so I'm kind of curious to hear your thoughts on that. How, if there's not an answer, how do we come up with an answer potentially? And I recognize this is a universal challenge for public health. How do we quantify the value we've added? So I'd love to hear your thoughts on how do we get to that.
Yeah, that's a good question, Erin. I don't really have an answer. I mean, I think there's probably different kind of epi modeling ways that we could try to like disentangle that question, but I'm not sure that I think it's that important. I think that obviously it would be nice to say like wastewater surveillance has prevented like X million cases or something like that. And that might be a nice tagline on any presentation or like in terms of trying to get resources. But I think like the stories and the visuals around like, you know, this is what the difference between case testing looks like now and what wastewater is showing us, and hospitalizations tracking with wastewater and not cases. I think those are more important, and I think probably more accurate than just saying we prevented X million cases or something like that. I mean, it's really hard, right? Like wastewater is just one piece of the pie. And to say that like wastewater has done these things, it's dependent on like what actions, you know, even if you have wastewater data, somebody has to do something with it. And what are you going to do with it? And, you know, was there case data, blah, blah, blah. There's all these other things, and wastewater is just a piece of it. So trying to focus on just that one question, I think may not be as helpful as it might be, given how complex it is. But I do think there's other ways to kind of make the same case that are like perhaps more engaging and more useful perhaps to the right audiences. I mean, I think different people will care about different things. So this is partially just to say I don't know how to solve that problem, but that would be kind of the approach that we've been trying to take, is come up with the targeted messaging around why we think it's been useful, and these are the use cases, and these are the anecdotes of why it's been useful. I think like Riva's case from Alaska is a really compelling story about why, right? That's to me more of a compelling story for wastewater than, you know, anything about X cases. I mean, that's just a statistic, right? So
I was going to say we have a lot of anecdotes, right? Like when we sequence all our samples, and when Omicron first appeared and the monoclonal therapies were no longer effective, we saw where Omicron showed up, and IDPH was able to put out word to local clinicians that your monoclonal therapies are not going to be effective. Same like Mpox, when we saw it in a facility, the ID doc there was like, okay, we'll tell the staff to keep an eye out for rashes, that they could be this, right? So, but I think it's a really good question. Like, how do we take these anecdotes and make them into, like, put them into something that's more quantitative or that you can sell? Do we need to do that? Maybe for like funding and stuff, and for the success of wastewater surveillance going forward. But it's it's complicated, but I think it's a good thought to take these anecdotes and kind of turn them into something more quantitative.
And I'll say too, that's a great question. And a lot of us in the lab, I mean, I think at times we've all been like, what is the usefulness of this test? We're all burned out from COVID. We're still just wrung out. But one of the best stories I heard in anecdotes was I had talked to a public health nurse, a county nurse down in Southern Iowa, and she was thrilled about wastewater. She's like, this is great. And so I just kind of was going over her data. She's like, what you're telling me is exactly what I'm seeing. I'm seeing an increase in cases. And she's like, I'm going to start putting messaging out on Facebook. I'm going to start with contact investigations again. So there, for once, I could tell people, look, at this is actually contributing to public health action. And so she was really excited to use that. And I think, like what you said, if there's a way to measure that, maybe it's the increased number of contact investigations, the number of public health messages going out. All those things are positives from wastewater.
Or the number of clinicians and public health departments that are using the data.
Yes.
I was going to say, just to echo that, but speaking more as a member of the public right now, I'm not wearing a mask. I didn't wear a mask on this whole trip. I know people around me on the plane and probably in here probably have COVID, but I looked at the graphics before I left and the current wave is decreasing. And I'm like, okay, I had COVID in April. I'm probably still marginally protected. I'm not going to wear a mask. And I'm not going to see my parents in Canada who are elderly, and I wouldn't want to bring it to them, even though they've had it more than me and they survived, thank God. But I'm thinking about from a public health perspective, having that big picture. Like, I would have been really annoyed if I didn't have that big picture. And I don't know how you quantify that, because it's not how many cases, but please don't take away my big picture. And I hope public health are starting to feel like that. It's that thing of, do I start testing again? Do I put more outreach effort out? You can't do that without the big picture. And I think that was mentioned by speakers in the first session too. If all you have is the cases in the hospital, it's too late. So, but I don't know how you articulate that, but you could try to do the counting cases, how many of you prevented. I think it's gonna be really hard to get to, but how you get people to say, hey, public health values the big picture. I was thinking about looking at, I use the weather app. And I look at, is it going to rain in my house, tomorrow or in the next hour? It's usually pretty accurate, but sometimes I'm like, hey, what's going on? And I zoom out to see all of Western North America. And I'm like, oh, there's a storm coming through, it's being able to zoom out and see the big picture. And I'm not sure, others can probably articulate that better, but I think we don't want to lose that.
Okay, we'll bump back to online questions.
Yeah, we've got a handful online. So one is, what are your key needs in detection techniques used in your labs? So in what ways are qPCR and NGS limited? And how do these methods prevent the implementation of an efficient pandemic preparedness system?
I'll say something. I guess I'll say something. I think, I think we have some differences in like you're building up your program. We did that in like 2021 with the same technology. And so there's different people doing things at different levels or different timeframes. And we're kind of learning from each other. We piggybacked on people who did it before us. I think one of the big limitations in terms of methodology is the fact that there's lots of people using lots of different methods. And so we think a lot about how we can compare. So if you want to zoom out and get that big picture of what's happening in this region of the US, well, how well can we compare our data when some people are using solid, some people are not, some people are using qPCR, some people are using digital PCR. We did a big switch in the beginning when we went from Abhilash's lab to mine, where we were doing like a filtration method and qPCR to where we're doing a more automated method with the nanoparticles and Kingfisher and digital PCR. And so we had to do a lot of like modeling of the data to be able to have continuity, to be able to look at what we did in the beginning to what we do now. And in comparing across different programs and different methodologies, I think that's a real challenge to try to figure out and how can we look at the data holistically and how can we zoom out and see and compare things. So I don't think there's like a limitation to a specific anybody can do it. Like you can do wastewater surveillance without the sophistication of these expensive technologies. It's just going to be different data, and how can we compare those is the question.
Yeah, I would totally agree. I also think that, as you get into this digital PCR realm, it's difficult testing. And when you have a public health lab like ours, it's just smaller. We have a lot of qualified, technically savvy people, but this test is not something that I would call routine by any way, shape, or form. So at times it's difficult to find. It would be nice in some ways if it was standardized. We're not there yet. But we've seen other programs, public health programs, become standardized, whether that's through the LRN or through PulseNet with whole genome sequencing. It can be done. It's been shown to be done. I do think that the more standardized we can get it, it makes it your basic bench scientist's job a lot easier. But it also sometimes makes the data less interesting too. So I think there's trade-offs there.
I would wholeheartedly agree, and also say we can't forget the level of technical expertise it takes to be able to do testing at this level, not just qPCR, but digital droplet, sequencing capabilities, all of those things. You have to build that level of technical expertise, and we are really grateful to all of our partners. It's a very collaborative field, but public health laboratories, just the space that they share, the ability that we have to engage in different communities of practice, predominantly through the APHL organization, helps us to be able to talk to partners, to know what to do. And just as you mentioned, Rachel, it's important for us to be able to collaborate where we can to make things a little bit easier. But without the standardization, the other question that we have is, when we look at the results, what exactly do they mean, and how do we best utilize those? And I think we're getting better and better at interpreting that and looking at how we can best use that data. But we still have a little ways to go, I think.
Erin, can I ask a related question from online? Then we can go to the room. Have proprietary lab methods and the associated costs limited your ability to develop wastewater monitoring targets, collaborations, and comparability? If so, how have you managed it? So proprietary lab methods.
No, I don't think it has. We've received nothing but help from plenty of people. I know Orange County was a big help in the beginning. Jeff Lottie in Washington was the one that turned us on to the nanoparticles. No, I don't think it has been at all for us.
I would agree. I think it's been helpful for us. Of course, our initial toe in the water, so to speak, toe in the wastewater for this particular endeavor was that we partnered with Ceres, and then we're able to better automate and bring up our capabilities that way. So when we started, we had already formed that partnership with them. They provided extensive training, and this was around fall of 2021, around Omicron time. And so it was beneficial for us because the sampling we were doing had some high levels in the wastewater for COVID-19, but it enabled us to be able to establish that methodology. And so I feel like they were just really helpful in establishing that. And then with the other, like we're just now onboarding ddPCR, QI-QD. And so I think that we're still in that process. But again, there's been just a lot of folks that are helpful, willing to share. And of course, the companies themselves have also been really helpful in getting us that established.
I can't think of it. Oh, sorry.
I was going to say one thing. There was, Biorad wouldn't tell us who else had an instrument like we had, and that was very frustrating. So, but I just took to the message board and went out and figured out who has QX1s and who doesn't, and we talked. So
yeah, I was going to say I can't think of anything that we do that's proprietary. We've shared samples with our wastewater samples with our friends in Wisconsin and sent things back and forth. I feel like this has been some of the most collaborative research that I've done, especially in the beginning when we were starting up and everybody was sort of in the same place. I mean, even with commercial companies, there's maybe some primer sets that are commercial primers that are proprietary sequences, but even those companies will usually tell you like what region of the genome it targets, or their CDC primers, or you can figure it out. So I think it's been really open. And if somebody thinks that things are proprietary, feel free to reach out and I will tell you everything that we do also.
Okay, we'll go back to any questions in the room. One over here.
Sorry to make you walk. I'm just curious, as we think into the future and look at, the next pandemic, which likely we're going to see in our lifetime, what are some of the barriers that we need to overcome today when we're thinking about disease X to increase the value and utility to that end user?
Broad surveillance. We're not going to find the next pandemic if we're only looking for COVID and it's not a coronavirus, we're not going to find it. So I think it's really like being able to use wastewater strategically.
And I think, so many things about COVID were unexpected, even for those that planned. Or were planners or were involved in planning. I was involved in really early flu pandemic preparations like 2006, 2007. And, it was my job at the time was to go out to areas locally and talk to all kinds of civic organizations, anybody that would listen, about how to plan for pandemic and an emergency, and you get about, I don't know, 7 minutes to hold their attention, tell them how flu can be transmitted and cause a pandemic. And bringing that to people that have never heard it, it's pretty shocking. And it was amazing how people were, oh, okay, so what are you what are you telling me that you want me to do, right? And so then taking those flu plans and seeing how we did and didn't utilize them for the COVID response, and how we thought we were prepared in ways that we weren't, and looking back on how to improve that, I think we have to take the lessons that we learned. And as a from the local public health lab response, I have to say the biggest lesson we learned is that response ended up being very, very local. And it was really up to us when things got really, really difficult. And I think for a lot of people, that was probably during Delta. When things were most difficult, the messaging was really important. The public health presence was really important. And the testing, getting the testing right for a public health lab was essential. So how do we, we talked today about timing and things like that. So I think making good decisions about ramping up our capabilities and being able to be prepared even when we're not in the ramp up stage, that is probably one of the trickiest things about pandemic preparedness. And then also, we have ideas about cataloging things like which pathogens are most likely to cause the next pandemic, how we'll respond to those, how we'll make treatments for those. All of those things are currently happening. And how do we continue to engage in that within the wastewater surveillance community? So maybe we can look at more, metagenomic analyses to kind of see what's there, but we have to very carefully interpret that so we don't overinterpret and hyper respond right after what we've been through. Yeah, thanks for that question.
Just to add a little bit to that, I think, a lot of trying to maintain and build on what we already have from a wastewater surveillance community. I think having that infrastructure be more robust and exist, I think when and if the next pandemic hits or when it hits, I think is really important. I think MPOX was a good example for us in California. I think we were able to leverage the infrastructure that we had and our partnerships with Stanford and SCAN and their ability to come up with assays quickly to deploy. We were able to start monitoring MPOX in California within weeks of the WHO declaration, and we found it in places we weren't expecting, in the Central Valley, places that are not like where you would expect, not like ports of entry and things like that, right? And that was particularly useful to us in California. And I think the corollary is like for whenever the next pandemic hits, it's going to come unexpectedly, probably, right? And we have to have the wastewater surveillance going. We have to have our partnerships and establish them with academic partners who have to stay interested, hopefully, and have the resources and the assays ready to go, even when it's, like a false alarm, like for variants, right? How many variants have we tried to track over time, right? And which one's going to be the one that's important? We don't know, but we have to keep trying. And then I think coordination, both on the kind of local, state, and national level, I think is super important to kind of let us know what's important and what's coming and what other people are seeing. I think that's really important. And of course, including kind of voices from other groups, right? From utilities, from environmental engineers, from all these other groups that really know a lot more about this than we do for wastewater surveillance. And I think it's really important to kind of keep everybody engaged and contributing to maintain what we have right now. And I think we'll be in a far better place next time around than this one.
You mentioned ports of entry, and I think it's a really good point too for finding the next pandemic, or is like sentinel sites and ports of entry and travel hubs and aircraft and things that we get samples from O'Hare Airport. So thank you all for contributing on your way into Chicago. And so I think that's also another really good point is looking at specific locations that are potential ports of entry.
And just to add a little bit to this, I hope that we keep the whole wastewater monitoring system that we have going, but in some sort of apocalyptic future when it's fallen apart, it's kind of worth remembering how we got started. We got an email from the state nonprofit organization that works for, basically does advocacy for wastewater treatment plants. So California Association of Sanitation Agencies, we get an email in late March, hey, Stanford is doing some stuff, Arizona is doing some stuff. Okay, and you start emailing back and forth. Who do we send a sample to? What exactly are we doing? But that's how it got started, because if you hit that one state organization, or if you hit NACWA, the National Association of Clean Water Agencies, they could connect you to all the state agencies. You can basically email every treatment plant in the states with two enders if you do that. So that's how to get a hold of us if you need us in the future, sometime down the line. The other thing was that it was the academics, and I may be wrong, but it seemed to be mostly the academic groups and some private companies that had a leg up that got going with the assays. And I think for the new assays, like Rachel's saying, having some sentinel sites, but keeping that tie to academia, and you guys in the academia are loving, I used to work in academia, so thumbs up. But the speed at which they can turn out a new assay. Our lab manager has a PhD in microbiology, and she said to me, we could be doing this stuff, but I don't have the staff. She would have had to justify the equipment and the staff. And in retrospect, I'm thinking, no way would she have had the staff to come up with a new assay every time there was a new variant. Versus, we send our stuff off to Stanford. Oh, here's your new variant test a week later. I'm like, okay, how do you people do this? So I think keeping those pieces of the puzzle, remembering that there are organizations that connect all the utilities, you can reach us all fast, and keeping, the academia tied in, somehow keep getting funding out to them while we're trying to fund public health as well. You have the pieces of puzzle that you can move fast when something happens, when the unexpected, finally happens.
We do have more online.
Okay.
Yeah. Okay. So here's another one. Let's say you have two buckets. In one bucket are data sets that are okay to share with the public without causing panic. This could be wastewater related data sets or maybe public health surveillance in general. And in the other bucket are data sets that is just better to keep kind of on the internal side of public health. How do you decide what goes in which bucket?
I think you have to decide early and often when you want to share that data or don't. So I think as we're developing these programs, it's important to consider, especially if you're considering looking at metagenomic data. So we do have an entity that we're partnering with within the UT system, and they are building out wastewater surveillance throughout the state and trying to recruit partners. And as we have engaged with them, some of the things that we've talked about is, can we look at, really this question of what's within that wastewater sample, an agnostic approach to really looking at the sequencing of, what's contained within that. And then when we look at that, what are we most concerned about, and when do we sound an alarm, and where is that trigger point? And so that's really all important when you're looking at buckets of data too. You want to think about, is this something that the public needs to know? And if they do, what are we asking them to do about it? Because definitely you never want to just incite alarm in the public. You always want to have the message of the ask of what you're asking them to do.
Yeah, this feeds a lot into the work that Creston has led and others talking about the ethics behind wastewater surveillance and what are we ethically obligated to report, and what sorts of data carry some sort of baggage that we have to be careful about. And I think it's something that as a community as a whole, it's something that you have to decide early and figure out.
We'll do one more question before we move on to our thought summary. So if there's anyone in the room.
Hi, thank you so much for all your input. So I hope it's not too specific, but I'm Susanna from Ohio. So when I'm thinking also about the future of the wastewater surveillance and all the different targets we are thinking about, which we could use. I'm thinking how we could make the surveillance network more flexible in terms of collaboration with the utilities. So maybe some targets we want to do, statewide, but some of them we want to, when there is an outbreak, maybe I really would like to, do some communities which we don't do regularly, but just kind of tap into them. So do you have any suggestion about how we could kind of make it a little bit more flexible, the networks?
We're thinking a little bit about using AI and modeling our data to and along with a whole suite of public health data to help inform like where to go. I think it's a big question, and there's been a lot of like CDC recently funded those national centers, and there's an NSF call out for the predictive intelligence for pandemic prevention. And I think all of these programs have the same idea, like how do we kind of have baseline surveillance balanced with surveillance that gets ramped up in response to things? How do you quickly respond? I think it's an important question, and we're trying to figure it out.
Okay, we can move on to our thought summary. So if each of our panelists could give just like a 2-minute summary of our discussion today, and we can start here with Alex.
Sure. Right. So, I mean, I think we I think we touched on a lot of different things, obviously, right? And I think there's a lot of different themes that people have talked about, I think, from ethics and data sharing and getting buy-in from different communities and partners, and the importance of those collaborations. And I think that's super important. I think for me, the where should we be going and how do we get there from a sustainability, and what is it that we want to do? Pandemic response, routine monitoring, flexibility to do outbreak monitoring, or other things like that from the public health side. And I don't know, trying to get the resources and buy-in from different groups, including from leadership and from like our own state departments or other things like that, I think are all key. But I think for me, it's the collaboration, and the fact that different people asking so many different questions, I think speaks to the number of different types of people who are interested and have a stake in this. And I think that's really exciting, because a lot of those are not necessarily things that, I'm thinking about or I'm used to thinking about on a daily basis. And it's been really good to hear that kind of feedback and thoughts.
Ryan?
Yeah, I think that's a lot to sum up. I think the important takeaways for me from this whole program is that it's a perfect program for public health. Like when I think of surveillance testing that public health labs do, this is what we do. It fits very well in our strategic plan, I guess, for lack of a better term. And I just think it's been really important for us to learn to rely on other public health labs and other university resources, and just to not be afraid to reach out and partner with other laboratories. I know we partner with Massachusetts and had a monthly call there for about 6 months. And I just think that, if someone reaches out to you, that it's important to return that favor too. But overall, I just think it's been a great learning experience, and it's been fun for us in the lab to get so involved with the epidemiology behind this. So.
Thanks. I would just say keep pushing the value of the big picture. If you keep the big picture, you've got it for flu every year, you've got it for RSV, you've got it for COVID if you want to. And if you keep working, not to just be all about us, but if you keep working with the large utilities that have the staffing to keep it going, then when something comes along, you've already got a network, and you can gear up and find the small utilities, and the big utilities can train the small ones in the area and get them on board. But you got to have the big picture value to keep all that going.
So I'm going to use a quote that's not mine, but I love it because I think it applies today to everything we've talked about. It is start where you are, use what you have, and do what you can. So you guys might be familiar with that quote already from Arthur Yancey, but in any case, I think that throughout our conversation today, all of the things that we touched on is, we have this wide scope of what we want to do, what we hope to do. And I think if we continue to work and collaborate together in the ways that we have and support each other, we really do have a bright future that we can hopefully sustain the programs that we have. And I've really enjoyed interacting with you all today and hearing all your questions. Thanks.
You'd think if I went last, I'd have plenty of time to think of something insightful to end with, but I didn't. But I will say that I think just the way that Anna and the organizing committee put together today and even this panel really exemplifies to me what successful wastewater surveillance needs, which is the partnership between utilities and public health and researchers. And I think we all need to talk to each other. And sometimes we have different languages and sometimes we have different priorities, but I think for it to be successful, that's what's really needed.
Great. Big thank you to all of our panelists and our awesome question askers. And I'll pass it over to Anna for any final comments before lunch.
All right, it is lunchtime. Just a friendly reminder to sign up for your breakout discussion groups out there in that little lobby. When you come back in after lunch, there will be table numbers on the table. So you can go to the first one you signed up for right after lunch. If you have any questions, let me know. There's grab and go food downstairs. There's also some restaurants in the digital agenda that you can walk to. It's such a nice day out there. Folks online, you will get breakout instructions. You'll be able to opt into your breakout room after lunch. So we won't be assigning you. Thank you again for a wonderful morning and have a great break.